This lecture gives a comprehensive coverage of clinical examination of cardiovascular system, including inspection, palpation, percussion, and auscultation. First heart sound is a high-pitched sound and is heard best with the diaphragm of the stethoscope. It is best heard at the cardiac apex. First heart sound is timed in relation to the carotid pulse as it occurs at the onset of systole. Interval between the first and second heart sounds constitutes the clinical systole, and that from second heart sound to the next first heart sound, the clinical diastole. A loud S1 is heard in mitral stenosis, while a soft S1 is heard in mitral regurgitation. Intensity of S1 decreases with decreasing left ventricular systolic function. In severe calcific mitral stenosis, when the valve becomes very stiff, intensity of S1 may decrease. Intensity of S1 increases in tachycardia when the diastolic period is shortened. The split of S1 is not audible usually, but may be heard in right bundle branch block and Epstein's anomaly of the tricuspid valve. In the latter condition, loud tricuspid component, that is T1, is known as sail sound, and it is due to the closure of the large anterior tricuspid leaflet. Second heart sound is also a high-pitched sound, better heard with the diaphragm of the stethoscope. Aortic component or A2 is loud in systemic hypertension and soft in aortic stenosis. P2 is loud in pulmonary hypertension and soft in pulmonary stenosis. Wide fixed split of S2 is a feature of atrial septal defect. Wide variable split may be heard in right bundle branch block due to delayed closure of the pulmonary valve. Paradoxical split can occur in left bundle branch block and aortic stenosis, but it is often difficult to appreciate in aortic stenosis due to the loud preceding murmur. Third heart sound is a low-pitched sound and hence better heard with the bell of the stethoscope. Left ventricular S3 is usually a feature of left ventricular failure and best heard at the apex. S3 in mitral regurgitation need not imply left ventricular failure, while an S3 in aortic regurgitation implies left ventricular failure. A right ventricular S3 may be heard medial to the apex beat in tricuspid area in right ventricular failure. Fourth heart sound occurs when there is a forceful atrial contraction and is common in the elderly with a stiff left ventricle. S4 is designated as an atrial sound, though it possibly originates in the ventricle. It can occur in acute ischemia of the myocardium when the relaxation of the left ventricle is impaired. Being a low-pitched sound, it is better heard with the bell of the stethoscope. Pulmonary ejection clicks become closer to the first heart sound as the severity of pulmonary stenosis increases. It is the only right-sided event which becomes more prominent in expiration. The phasic nature is due to changes in the pulmonary hangout interval. Hangout interval is the time delay for closure of the pulmonary valve after the crossover of pulmonary and right ventricular pressure tracings. Longer hangout interval of the pulmonary valve than the aortic valve is due to lower resistance of the pulmonary circulation. A phasic aortic ejection click may be heard in tetralogy of Fallot. It is a vascular ejection click due to the dilated aorta which receives blood from both ventricles. Opening snap is typically heard in mitral stenosis, though it may be there in tricuspid stenosis. It is seldom appreciated in tricuspid stenosis. Opening snap is a sharp, high-pitched sound heard better with the diaphragm of the stethoscope. It is heard best slightly medial to the apex rather than at the apex, where the murmur is usually loud and masks the opening snap sometimes. Opening snap occurs after the second heart sound and is earlier in severe mitral stenosis. Hence, S2-OS interval is inversely related to the severity of mitral stenosis. Opening snap disappears when the valve becomes non-pliable with severe calcification. The mid-diastolic murmur of mitral stenosis starts immediately after the opening snap. Tumor plop occurs soon after the second sound when a pedungulated atrial myxoma, right or left, pops into the tricuspid or mitral orifice in early diastole. It occurs when the diastolic movement of a tumor with a large stalk into the ventricle is abruptly stopped. Pericardial knock is an early diastolic sound heard in constrictive pericarditis. It is also called an early S3. The sudden rush of blood from the atria to the ventricles is halted soon by the thickened pericardium, which causes restraint for ventricular relaxation, leading to the pericardial knock. Pericardial rub is a superficial scratchy sound which is better heard with the person leaning forward. Intensity increases when the diaphragm is pressed on the chest wall. It persists on breath holding and is synchronous with the heartbeats, differentiating it from a pleural rub. Pericardial rub is triphasic with one phase each in systole, diastole and atrial systole. All phases may not be heard always, and it is well known to be evanescent. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.